Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. We've designed our curricula to elevate your confidence in this specialized field. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. So the upside of MRI, we can differentiate osteomyelitis and reactive edema. And it's powerful also to differentiate neuropathy from osteomyelitis. And of course, neuropathy from infected neuropathy. And this is that example where we can see that marrow infiltration along the third metatarsal and also along that fibular sesamoid. Notice that the fibular sesamoid is not actually enhancing on post-contrast imaging shown here. So that actually is reactive edema, but we can see the enhancement of the bones here. And of course, that marrow replacement is enhancing with abscess and pus extending dorsal and along the extensor tendon in this patient who has osteomyelitis and septic tenosynovitis. So why do we perform MRI? The purpose in the diabetic osteomyelitic patient is to define the extent of the bone and soft tissue infection. This can help guide the surgeon preoperatively and also can help us follow the case. The sensitivity in MRI, very high, upwards of 99%. It does have a range in diabetic feet. Specificity, the ability of the test to detect the disease when it's present, 81%. And here we can see in this X-ray evaluation, my big arrow is pointing to this region of this juxtaarticular osteopenia seen in this location along the MTP joints. And we can actually see this vague area of lower attenuation or these low attenuation densities seen in the soft tissues. And that on this post-contrast imaging is showing itself to be an abscess in that area of the metatarsal, deep to the metatarsal fat pad. In terms of differentiating osteomyelitis and reactive edema, we're primarily going to be looking for where is the ulcer. It's imperative that we have our technologist or the clinician give us the history of where the ulcer exactly is, or if the ulcer is healed, we want to know where it was. And we know that because in order to have the situation when we have diabetic osteomyelitis, it's always connected to the ulcer in some way. So the ulcer creates a space like we saw in our previous tutorial. The ulcer creates the situation where infection can go right and directly spread into bone. To understand what is osteomyelitis, we look for T1 infiltration. So the geographic, what I call the splotch sign, is when the entire marrow is splotched out with this T1. So it doesn't have to be as large as this, but the idea is that we do not have osteomyelitis without T1 marrow infiltration. That's one of the cornerstones of the disease. We can use secondary signs to help us, such as periosteal reaction. Of course, this presence of a skin ulcer may be there and not have osteomyelitis. Sinus tracts, looking for a small tract that's going from the region of an ulcer to the involved bone. Very important, especially when we're dealing with evaluating stump, like the stump. If someone has an above knee amputation and they have a small pinhole defect, we can often see that tract going right into the bone and causing osteomyelitis. Of course, secondary signs looking for cellulitis and abscess. And here we can see again our marrow infiltration along the third metatarsal head. And of course, we see it here, this infection infiltrating the third metatarsal head and the soft tissue infection dorsal within the joint space and decompressing dorsally. So in terms of the diagnosis of MRI, they looked at a retrospective evaluation from 96 to 2002 and found that 80 patients that had MRI with a diagnosis of osteomyelitis, all of those patients went to surgery, and within 6 weeks of the MRI, they found the results and compared the results of surgery to MRI. And they found that MRI was truly positive in 59 out of those and falsely positive in 21. The T1 low confluence signal in the geographic pattern was present in 100% of surgically proven osteomyelitis cases. So we use that as the cornerstone of our diagnosis. And the majority of false positives are when the reading physician was saying that there was a hazy reticulated pattern. So independent of T2 or post-contrast enhancement, None of these patients who had that hazy reticulated pattern had osteomyelitis on this study done by Collins. Are you ready to take your podiatric imaging skills to new heights? Check us out at radpodsquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.